Yeah, Chattopadhyay. He's our worker from Lucknow, CDRI, who has done excellent work on this. It shows that how rituximab stabilizes the sclerotin. So now the bone turnover markers, that is monitoring anabolic response, the formation markers, the P1NP, bone-specific alkaline phosphatase, reliable but slow to change. P1NP is a procollagen of type 1 terminal N-telepeptide. The most sensitive marker rises with 1 to 3 months of anabolic initiation. So when you start an anabolic therapy, you recheck the P1NP at the end of 3 months, you will find the formation is increased by looking at the marker. Osteoblast specific protein correlates with the bone turnover rate, that is the osteocalcin. Whereas the resorption markers are the CTS and NTX. C-terminal telepeptide is a gold standard for resorption marker suppressed by antiresorptives. N-terminal telepeptide, which is the urinary deoxypyridine alternative when CTX is not available. So when you do a CTX, you're doing it in the serum. When you're doing NTX, you're doing it in the urine, not in a simple sample, but a 24-hour collection. So monitoring P1NP at the end of 3 to 6 months confirms there is an anabolic response and the guide the sequential therapy decisions. So what are the anabolic agents and mechanism and evidences? The PTH teriparatide is 1 to 34, which is an analog of PTH fragment, is the first 34 amino acids. Intermittent PTH1 receptor activation produces a net anabolic effect by it stimulates the osteoblast proliferation and differentiation, inhibits osteoblast apoptosis, extending their lifespan, increases bone matrix synthesis and IGF expression, improving cortical and trabecular bone volume and microarchitecture. The dose is 20 micrograms subcutaneous daily, maximum per period of 2 years. Now, once weekly formulations are also available. In the clinical trial evidences, there has been 84% reduction in the vertebral fractures. The fracture prevention trial, where they are given 200 micrograms of teriparatide compared to placebo, there is a significant reduction and multiple fracture reductions, vertebral fracture reduction. When you have risk of 2 or more vertebral fracture, it has been reduced significantly in the fractional prevention trial. Then vertebral fracture reduction in the weekly teriparatide injection, once weekly teriparatide, showed a 79% reduction, almost similar to that of daily injection. The lumbar spine BMD gain is about 11%. So there is an increase of about 9 to 13% over a period of 8 to 24 months. That is roughly 2 years. Albuperitide is a selective PTH receptor agonist, structurally resembles a PTH-related peptide. It's a key pharmacological advantage. It lies in greater selectivity of the RG conformation of the PTH1 receptor, producing more transient receptor activation. The clinical consequences: low hypoglycemia risk compared to teriparatide, less sustained GMP cyclic AP signaling, greater gain of BMD, clinically important given fractures of the morbidity, greater reduction in the major osteoporotic fractures in the active trial versus teriparatide, no significant difference in vertebral or non-vertebral fractures between the agents. The teriparatide has a receptor selective activity, hypercalcemia risk is high, whereas in albuperitide, receptor selectivity is higher when compared to teriparatide. Hyperglycemia, calcemia risk is lower. Gain in the BMD is higher. Fracture reduction is much superior. Duration is again for 1.5 years. Romosozumab is a dual action sclerotin inhibitor. It is a homogenized monoclonal antibody against sclerostin, removes the brake of wanton B catecholamine signaling simultaneously, stimulating the formation. So the formation effect is dramatically but transiently stimulates the bone formation, which peaks at 1 to 3 months, the anabolic effect. So, and disappears by 6 to 9 months of continued treatment. So resorption persistently reduces bone resorption throughout the 12-month treatment course, a true dual agonist. Dosing is 2 times subcutaneously once in a year, followed by mandatory antiresorptive to consolidate the gain. So you are given it 12 months only, once in a year, then you have to consolidate the gain by preventing an antiresorptive by giving antiresorptive zoledronic acid or denosumab. The frame and the arch trial shows romosozumab with placebo. There's 73% reduction in vertebral fracture at 12 months, 75% at 24 months after transition to denosumab, and the new vertebral fracture with romosozumab is only 0.5% compared to 1.8 in placebo. This is from the frame trial. In the arch trial, romosozumab is compared to alendronate, the first head-to-head RCT demonstrating superiority of anabolic agent over bisphosphonate. Romosozumab, alendronate outperformed alendronate to alendronate. So if you're going alendronate to alendronate, antiresorptive continuously, or giving anabolic to an antiresorptive, which is better. So our trial established anabolic first paradigm, starting with romosozumab, provides superior factor protection when compared to starting with bisphosphonates alone. So this is a head-to-head comparison of the three agents, teriparatide, alboparatide, romosozumab. The mechanism is PTH1 receptor agonist, alboparatide also thing. Romosozumab is an anti-sclerostin, which has got a dual action. This is daily. This is also daily alboparatide, whereas it is monthly for a period of 12 months. This is for 18 months. This is for 2 years. So you see the superiority of the drug is going up, the duration of therapy comes down, and the BMD gain is much higher here when compared to the teriparatide or alboparatide. So post-therapy, mandatory antiresorptive in all these drugs which you'll have to complete. So in special populations, male osteoporosis is approved for teriparatide. By network analysis, it has been shown the lower BMD gains versus antiresorptives, an increasingly recognized condition with high fracture morbidity. The glucocorticoid-induced osteoporosis, the teriparatide is superior to ritonavir in GIOP, greater lumbar spine gains from fewer vertebral fractures, and anabolic therapy directly counteracts the glucocorticoid-induced osteoporosis suppression. In postmenopausal women, only in severe cases, the clear etiology, teriparatide uses off-label romosozumab not recommended. So in postmenopausal women, use only in severe cases with clear etiology. Teriparatide is used off-label. Romosozumab not recommended. Genetic work strongly advised in early onset osteoporosis of less than 40 years. Safety profile: hypercalcemia, nausea, leg cramps, prior malignancy or bone metastasis contraindicated. Pages diseases, prior skeletal radiation don't give. Pediatric patients with open epilepsy don't give it. Romosozumab injection site reactions can occur with arthralgia, black box warning of increased MI, stroke, and CV deaths. History of major CV events in the past 1 year. Osteosarcoma is seen in murine models, not in humans. And always the cardiovascular history has to be applied before using romosozumab. Do not use within 1 year of MI or stroke. So we have a postmenopausal osteoporosis with high risk for fractures. Patient profile is woman with multiple fractures of -3 lumbar spine bone density, prior bisphosphonate failure. Treatment is romosozumab 210 milligrams monthly for 12 months. Transition to alendronate. Significant BMT reduction at the lumbar spine and hip. The lesson is romosozumab is effective first line in very high risk postmenopausal osteoporosis. Now, from the discussion, you find you have to define it's a bisphosphonate failure. What is a bisphosphonate failure? New fracture on therapy or inadequate BMD response, less than 3% gain at the spine after more than 12 months of therapy. Either criteria justifies escalation to anabolic therapy. Why romosozumab in this case? Because it has got a dual action, decreases the resorption, increases the formation, provides faster BMD gains than PTH1 receptor agonist. Ideal when the rapid fracture risk reduction is a priority. Critical role of sequential therapy. Sequential alendronate after romosozumab. Critical role of sequential therapy. Alendronate or after romosozumab consolidates BMD gain. Stopping without antiresorptive following through leads to rapid bone loss reversal within 12 months. Monitoring protocol, DEXA 12 to 18 months, Do the P1P at third month to confirm there is an anabolic rise. A more than 10% rise is very important. Pregnancy and lactation associated osteoporosis. 20-year-old woman with severe vertebral fractures. BMD spine is minus 4.7. Teriparatide anabolic therapy followed by denosumab. Step 3, romosumab chosen when a biological plausibility of anti-sclerosing restores the pathway. Extraordinary outcomes. BMD 42% increase at the total heap, about 16%. The mechanism of action is logic, impaired colonial one signaling, early onset osteoporosis, sclerosing inhibition, particularly compensating for the receptor defect, a biologically elegant rationale. So, pregnancy and lactation associated osteoporosis, a rare but severe condition, but often presenting with multiple fractures in the third trimester of postpartum. Calcium mobilization during lactation and transient PTH-RP elevation are contributory mechanism. So, here the genotype guided selection action, WNT1 mutations impair colonial 1 signaling, romosumab which is restores this pathway. This is biologically rational genotype choice, not possible without genetic testing. So when to request genetic testing? In anybody who has got an osteoporosis of less than 50 years of fragility factors and severe BMD deficit or inadequate response to standard anabolic therapy, you should do. Clinical peril is genotype guided anabolic action selection can dramatically improve this monogenic osteoporosis. 42% of lumbar spine BMD gain in this case is among the highest reported in the literature. So osteoporosis, osteogenesis imperfecta is something is a trial drug which has been where there is a BMD of less than 5.56 recurrent fractures with prior alendronate failure. 1 to 12 months of romosumab plus LD calcitriol. Lumbar BMD gains is about 22% and hip gains about 136. Bone formation increase, resorption is decreased, no neo fractures. So this is what has been tried in this patient who has been given romosumab. Well, this is very, very rare condition, usually not much used by any clinician generally, except a few endocrinologists do it. So osteogenesis imperfecta is a defect in the collagen type 1 structurally fragile matrix. Bisphosphonates suppress modeling and may reduce the fracture frequency, but do not build the matrix, which is a limitation. Sclerosin levels are elevated in osteoporosis. The preclinical osteogenesis OA models, genetic pharmacological sclerotin inhibition promoted new bone formation, providing the biological rationale for romosumab. Interpreting the 136% heap gain, extraordinary percentage of severely depleted basal BMD, absolute values remain important. The magnitude of gain would be impressive with anti-resorptive therapy alone. So romosumab is a viable option in rare bone disorders refractory to bisphosphonates. Evaluate the sclerosin pathway when selecting anabolic therapy in OA and related conditions. Well, glucocorticoid-induced osteoporosis, teriparatide is the treatment of choice. We are going to see a middle person of long-term prednisolone for autoimmune disease with a T-score of -8 with new vertebral fractures. Classic glucocorticoid-induced osteoporosis, osteoblood suppression, osteoclast activation. Treatment is a combination strategy, denosumab with romosumab. You combine it. The data trial shows combined teriparatide demand denosumab superior to a monotherapy. Combination prevents the resorption surge that allows anabolic therapy. Lesson is glucocorticoid osteoporosis may warrant combination anabolic and anti-resorptive therapy in refractory cases where the fracture risk is high. So the track is GIP suppression inhibits the osteoclast, teriparatide and romosumab restores the osteoclast. On anti-resorptives, denosumab prevents the resorption surge and durable GMD in a few fractures. So sequential therapy in osteogenesis imperfecta, romosumab anti-sclerosing therapy, teriparatide agonist, and romosumab re-challenge is what is being tried in a way. So mechanistic sequelae is switching between agents targeting PTH, RP, and sclerotic may provide additive or synergetic effect. Romosumab teriparatide transition, it can maintain the anabolic momentum through this pathway, preventing the BMD plateau, typically following a romosumab. So the evidence gap is there is no head-to-head RCT trials and is limited to case reports in a small series. Clinical lesson is individualized sequential strategies representing an emerging frontier in complex osteoporosis management. This should be reserved for specialist centers managing refractory osteoporosis. Clinical management, evidence-based algorithms for monitoring protocols. So when you have T-score less than minus 2.5, multiple fractures, and anti-disruptive failure, so the very high fracture risk or glucocorticoid-induced osteoporosis, you have to give PTH1 receptor agonist, that is teriparatide, albuperatide, or romosozumab, faster gain of BMD. So you select, when you're selecting, the CV event is not there, you give romosozumab. If the CV event is high, you give albuperatide. After 12 to 24 months, you consolidate with the anabolic therapy. Anabolic therapy for 12 to 14 months, transition to antidisruptive maintenance and annual reassessment. So monitoring a treatment, baseline, do the DEXA, CTXP1NP, 25-hydroxyD, and EGFR. After 3 months, repeat the PMP. It should raise by about 10%. 6 months, recheck the calcium with renal function. And then the injection technique. At the end of 12 months, repeat DEXA. Then annually, you do the fracture assessment and you will get a targeted T-score more than 25. So cost effectiveness, low risk, not cost effective for any agent. Moderate risk, cost effective for teriparatide generic only. Cost effective for teriparatide and more than minus 2.5 to 3. All agents are effective, including romosozumab, with greatest quality benefits. Very high risk of fractures. It comes with a cost also. So emerging trends or the newer drugs, which we are not going to discuss here. The takeaway message is act early in very high risk patients. Anabolics are the first line of very high osteoporotic risk. Consolidate whatever you gain with osteoporotic therapy. Choose wisely. CV history, malignancy history, etc. Think of genetics, genetic workup in early osteoporosis. Monitor P1 and P at the end of 3 months. Thank you.
Thank you very much, sir. Thank you for giving the picture. Please, Sik, sir, any question is there?
Anything? Anything, Abhijit? You are muted.
Yes, sir. No, sir, everything is done, sir. Thank you very much, sir.
We can close down.
Yes, sir, we can close down, sir.